Hello everybody. 1 year has passed and I am introducing new educational course, Masterclass Zero Bone Loss Concepts Immediate. Now, for those who were not really familiar with my education platform before, I'm extremely happy to tell that Zero Bone Loss Concepts course, which we launched about 1 year ago, was extremely successful. We had over 700 students who took the course in different ways of learning. And during the launch of the course, I already understood that immediate implant placement will be another topic which we will going to be discussing. Of course, before we start talking about immediate, let me introduce myself. My name is Professor Tomas Linkevičius. I'm coming from Vilnius, Lithuania, and for the past 15 years I have devoted my time and energy and work to research factors which are important for crestal bone stability of healed ridges. Of course, we are now living in an advanced implant placement world. That's why without immediate implant placement, we cannot provide sufficient treatment for our patients. But let me just remind you that previous course, like the basic course of Zero Bone Loss Concept, was based on clinical evidence. So it was not just another course where I was discussing my opinion. All our works were really based on clinical evidence. And of course, it is important to mention that the book, Zero Bone Loss Concepts, which was published 2 years ago, now it's published in over 10 different languages. That shows that crestal bone stability still is the topic number one in implant dentistry. Well, Zero Bone Loss Concepts was successful. Now, what about Zero Bone Loss Concepts Immediate? How do these factors, which we were discussing in previous edition, are they important for immediate implant placement? Or in what way they are important? What will happen with the tissues and implant design and the height of tie base when we place implant into extraction sockets? Looks like a not very different change, but from crestal bone stability, this is an extreme change between healed ridges and immediate implant placement. Now, maybe some of you remember this important slide from previous masterclass, the combination of implant design factors and biological factors. Is this equilibrium the same here in immediate placement? Or maybe implant design factors are here more important? For example, stability, primary stability, which is completely not an issue with the healed ridges. So maybe in immediate implant placement, implant design factors will be more important. Or vice versa, maybe, let's say, tissue thickness in aesthetic areas is much more important for the patient than implant design. So these things, of course, we are going to talk about, and the famous discussion about that factors for bone stability are apples in the basket. Maybe they are not relevant when we talk about immediate implant placement. So all these things we will talk about in this very, I think, interesting masterclass. And I'll start this with my first immediate. So I have really documented the first time I placed implant immediately, and that gave me a lot of inspiration, and of course rose even more questions when we talk about the success of the treatment. So my first immediate case was 2015, so only 6 years ago. So I think that's also a factor here. So my first case was fractured canine of the patient. And when we evaluate, of course, first thing we do in immediate implant placement, we evaluate, is it really possible maybe to restore this tooth, not to extract? So here we see canine which is not endodontically correctly treated. We see root fracture, and this is the situation before fracture, and this is situation after the fracture. And here again another issue, that endodontically treated teeth, of course, are very weak ones, and we should never leave endodontically treated tooth like here just filled with composite. So the tooth has fractured, and we see almost no coronal dentin. So of course we need really to first of all make a decision to extract or not extract. So here my choice was extraction, because when I evaluated what needs to be done in order that this tooth would be saved, so you need to endodontically retreat the root, you need to make a post and core. Of course, probably you will need to make a metal because lack of coronal dentin. Then afterwards you will have to have canine guidance because it's a canine. So I think that probably the better choice would be implant placement, because it's much stronger compared to all these steps which are needed to be taken to save this tooth. Anyway, that was my decision, that we extracted the tooth and followed up with all the treatment. So of course, first of all, careful extraction of the tooth. You see the separation of the roots. We'll talk about this very extensively when we will discuss how we need to extract teeth before immediate implant placement. And positioning of the implant palatally. And on this picture you see how deep the implant is placed. So when I was placing it 6 years ago, I thought maybe this is too deep, and this is the question which we ask ourselves many times. So we'll learn later what is the correct position of the implant, because that is the question number one I am asked when we talk about immediate implant placement. So how deep the implant should be placed? Below the bone, in terms of gingival margin position, depth of the implant placement is really important factor. Okay, let's go back to this case. We placed the implant, we grafted the bone, the jumping distance, and provisional restoration was manufactured and screw-retained to the implant. Now here is important issue, especially when we talk about canines as immediate implant position. Why? Because usually canines are longer, that they would have a canine guidance. This is what you need to avoid in immediate, of course, implant placement. We should not really have a contact during eccentric mandibular movements, especially in canine guidance. So here you can see that the canine provisional restoration was trimmed that it would be about 1 millimeter out of not just static occlusion, but also out of the mandibular movement. And after 4 months, we see a really nice healing. You see that the contour of the tissues is really maintained. And here we see just after delivery of the provisional restoration, and here we see after 4 months of the healing. So completely no change of the contour. Now at that time, 6 years ago, I was not really deeply into immediate implants, and I did not really raise myself the question, so which factors led that the contour after extraction of the tooth, implant placement and provisional led to this contour which really did not change after extraction of the root? Because we were really, of course, we know that when we extract the tooth, everything collapses. So when I removed this provisional restoration, I was really amazed when you can see that the contour is perfectly maintained. So this really never happened when you do delayed approach or early approach, when you extract the tooth, let everything collapse, and then you start to rebuild. We'll talk about this later. Is it wise to do that? And probably the best choice would be, as you can see it here, that place implant immediately and then not allow the tissues to collapse. Before implant placement, before extraction of the tooth actually, and 6 months post-implantation, and you see how nice the contour is. Now for this, now we have rules. We understand now why we had this emergence profile, as you can see here on the picture. And when I was taking the impression, you see that the transfer, open tree transfer, is really deep. It means just the part of it is covered with impression material. Of course, in this case, I use my method of stabilizing open tree transfer by using occlusal material, which I discussed in previous masterclass. But this line, when you can see that the depth again of the implant, again I go back to this, and I will talk about this in upcoming lectures, that this is so important, because if you place the implant not in correct position apicocoronally, sometimes you can really do not get a good aesthetical outcome. Well, the final restoration, super smooth polished zirconia restoration, because I am using this way to restore implants already for 10 years. Super polished zirconia, no glaze, and for those who really took the first course, you know, this is completely clear. I don't need really to elaborate on that anymore. However, let's follow up a little bit. What happens with the tissues when we, you know, restore them with super polished zirconia? And the patient after 1 year follow-up, the patient after 2 years follow-up, you see the tissues are really getting thicker around immediately placed implant. And this is extremely clear in these two clinical images, just delivery photo and follow-up photo. You can see that these tissues really grow over super smooth, super polished zirconia without ceramic glaze. Now again, keep in mind that this is an immediate implant placement and later restoration. Screw retained, single crown, delivered to immediately placed implant. occlusal opening covered with tape and then with composite. This is like our ordinary way of working. And now let's follow up a bone a little bit. 2015 placement, 16 restoration, and 5 years follow-up. So we see 0 bone loss immediate. No really bone loss below the neck of the implant. Sure, there is some remodeling above the neck of the implant, but that is completely no threat to the longevity of the implant. And this is clinical picture of 6 years follow-up. In my opinion, this is a really perfect outcome of immediate implant placement, because keep in mind and just look at the neighboring teeth at nearby incisor and see the gingival, the hygienic habits of the patient. And of course, I could, before taking the picture, I could remove the plaque, because maybe it is, does not look so good on a clinical picture. But the point is, I want to make the point that this is our patients. After treatment, they rarely, sometimes do not go back to cleaning teeth precisely. So in other words, even with that bad plaque control, when you look at this immediately placed implant, you see completely no bone loss, and you see perfectly glued, adhered tissues to the surface of the crown. What else can we talk, and we will discuss this later in ongoing parts. Okay, what about the depth? How deep is this implant? If we compare it from the crestal bone, so it's subcrestally about what, 2 millimeters. But if I measure it from the contact point of the neighboring teeth, it is about 10, 11 millimeters below the gingival level. Now, is it good or bad? I mean, if we are thinking about usual ways, what our, let's say, historic literature tells us, that probing depth should not be more 5 or 7 millimeters. But that implant, has about 11 millimeters and is really working without any problems. So maybe we should rethink our, let's say, dogmas regarding the position of the implant and regarding the probing depth, because, of course, here we can see, we must keep in mind that this implant was restored with super polished zirconia. So of course, if I would restore that implant, let's say with metal ceramic crown or glazed crown, sure that 10 to 11 millimeters probably would have resulted in the pocket. But here, since we have a smooth zirconia where you have adherence of the tissues, you have gluing via hemidesmosomes of epithelium to the surface of polished zirconia. So that's why I'm completely not afraid of having implant position like you see it here. Furthermore, I would advocate this implant position because in immediate implant placement, sometimes you go even too deep in order to gain primary stability. So those things, those factors, we'll talk about how to get primary stability, what implant design is needed for that. But again, this clinical simple case gives us really a lot to think about. Another issue, you probably have noticed it already. What about this tiny micro gap between tie base and zirconia? And also, what about the cement, resin cement, which is used again for connecting zirconia to tie base? Again, these are also these dogmas which we must overcome. For example, that resin cement is completely not toxic in this kind of the treatment. We must really forget about this, because all toxic, let's say, studies of toxicity with resin cement or cement are made on cells, are really not in the living organism, which we are. So these things, let's say this first clinical case which I did 6 years ago, really validated a lot of things which we are now taking as a granted, that position of the implant, superpolished zirconia. But the point, of course, here is that this was done in immediate fashion. Well, now what we're gonna talk about then in all this immediate masterclass? We'll talk about what is rationale for immediate implant placement. So why should we place implants immediately? And maybe why we shouldn't place. Another topic we'll discuss why immediate implants are successful. And again, this is a myth that immediate implants have lower success rate than delayed implants, and that's why we should not do immediate. This is really a wrong way to talk about. If done correctly, I think that immediate implants are even more successful than delayed approach, which we were used to do for many years. We'll go into specifics. I'll separately talk about what we do with immediate molars, then how to do immediate anterior restorations and implants and premolars. Really, we'll section our mouths into 3 big segments and discuss how to do immediate implants in those regions. Of course, I'll reveal all restorative secrets, because that is also different from healed ridges. And there are minor differences, but those are of the major importance. Let's say the height of thigh base, and why we sometimes can use even a low thigh base for restoring of immediate implants, which would not be possible to use in cases with healed ridges. Complications. Of course, every treatment and every clinician has complications, and I'll really show you mine, and I'll also explain the lessons which we got and what lessons did I learn, and to avoid future complications. There will be a lot of surgery, live surgery videos of anterior implant placement, posterior implant placement, and many things which will start when we will taking the course. So let's begin then with first topic. Okay, so what is the rationale for immediate implant placement? So in what cases should we place the implants? In what cases we should not? If we place, how we do that? But you know, this is a really large, a broad topic. So let's divide those a little bit into the smaller segments, which will really help us to understand. So this topic, I'm going to talk about how to say why we need to change our point of view. So not a lot of numbers now, but philosophical point of view, because that really happened to myself. 6-7 years ago, I was not so well into immediate implant placement, and there are reasons for that. But in order to dive into immediate implant placement, first of all, you need to change your thinking and change the way you work. Because now, when I extract the tooth, actually even before extraction, first thing I look and think, can I place implant immediately? And if it's not possible, and there are limitations, only then I think about delayed implant placement. So again, look, completely changed point of view. First, I think, because I really believe and I'm gonna show the advantages of immediate implant placement in, let's say, almost every situation. Okay, so why should we do immediate implants? The question mark. Now, specific advantage of immediate implants. There are specific things which you can achieve only by placing implants immediately. Sometimes, if you do not place implant immediately, you are losing tissues, you are losing the bone, and then later to go back to this time point becomes impossible. So there are some specific advantages of immediate implant placement which we're going to discuss. Well, if immediate implants are so good, so why sometimes immediate implants are still considered risky? Now, again, if I still sometimes I am amazed when clinicians who work for 20 years are still not doing immediate just because of this sentence. Immediate implants are considered risky, more risky than conventional implants when you're placing into healed ridges. Now, is it true? And if not, why did we have this notion that for some reason these implants are more risky compared to healed ridges? Of course, the most important part here, immediate or early implant placement in aesthetic zone. So that's really the driving range and driving, discussion. If I am getting extracted central incisor, should I receive the implant, or should I go to all this long path of provisionals, reconstructions, and other things to get the tooth? Or maybe we can do it immediately and really save a lot of time and provide the better result. So that's important. We're not talking about getting the same as in delayed approach. Sometimes we talk about getting better result with immediate compared to delayed approach. Advantages, disadvantages of immediate placement from clinician point of view, from the patient point of view, and of course contraindications, because there are, immediate implant placement is not for all the patients. So there are cases in single implants and in other implants as well when we should not do immediate implant placement. So that's the point that we really need to select the cases, and once we do it, then it is possible to achieve the best outcome. Okay, so you are ready? Let's go and start about answering this simple question, maybe a stupid question for some. So why should we do immediate implants? Maybe the question should be, should we do immediate implants? Now, is it, maybe it's, we need to stay on this safe path which we were standing many years before, or should we really go further and take the next step into immediate implant placement? Well, what about this? Extracted molar. You see a nice profile, you see a lot of bone. Should we do immediate here? I mean, yes, no, yes, no. I would do immediate here. What about premolar? Looks, again, should we let all these nice tissues to collapse and then start reconstruction? Or maybe just the place implant right now, do some grafting, do individual healing abutment or provisional restoration, and keep this profile as it is. Anterior cases. Should we do immediate here? When you see a lot of bone, you see thick tissues, or how to say, tell the patient now you'll have to wear provisional restoration, removable restoration for half a year until you get your final tooth. So those are questions which first of all we need to answer. Without believing, without understanding what you are doing and how immediate implant works, then this is a bad way of working. This is really a direct way to receive a complication. So the thing which I started, and I think this is a good way for you to start as well, is to understand that after extraction of the tooth, if we do nothing, we have a collapse. Collapse of the tissues and collapse of the bone. So the bone shrinks, tissues shrink. We'll talk about why that happens, but it's the fact that you are losing the bone. And we, for many years, are really comfortable in doing a delayed implant placement when you have really already healed bone, and then it's easier, because some consider that immediate implant placement is easier than delayed. No, no, no. That's completely wrong assumption, because just look at these two clinical pictures in which case it would be easier for you to insert the implant. When you have around healed bone is healed, and you make osteotomy and insert the implant, and here you have a hole. You know, you extracted the tooth and there is a hole, and you are placing the implant in that hole. And the implant, you know, is not stable. It can go to the direction of the least resistance. So it means that it's for you to malposition the implant in immediate situation. It's much, much more easier compared to the healed situation. So first of all, I would say that I completely disagree that immediate implant placement is easier. It's easier to make a complication with immediate implant placement than the healed ridge. So that must be clear for you. Before you start immediate placement, you must really understand why you are doing this and what the outcome will be. And the outcome can be fantastic. Just look at this clinical cases. This is delayed implant placement and the restoration when all the tissues collapsed, and this is how the tissues look after immediate implant placement. And not just the implant placement, there is all protocol. So we must forget about that I would place the implant and magically it will do something with the tissues under the bone that I would end up with a result like that. No, there is a strict protocol which we will discuss. However, when I look at this nice profile of soft tissues and the bone over immediate implant placed immediately and restored, I never really had this outcome with delayed implant placement. So with delayed implant placement, usually you are getting this instead of this. Is there a difference? We'll learn that from patient perspective it is. Now, is there the difference for you as a clinician? Of course it is. The time, the chair side, it is much faster to do with immediate placement. And if the result is as equal, or as you can see it here, in majority of the cases even better compared to delayed approach, so why don't we go immediate? Why don't we do that? Again, as I said, as this part of the master class is really talking about changing the mindset from delayed mindset to immediate mindset. Of course, another personal story and experience. So when I started to make immediate implants, I had one of the first cases was this patient. And I had a chance to really do on one side of the patient's mouth to do immediate implant placement, and on the other I had a chance to do delayed implant placement. So I could compare in the same patient two ways of treatment, and we could compare then the outcome. We can compare the bone stability, soft tissue stability, patient satisfaction. So as I said, inter-patient comparison of both treatments is the best case scenario. So we can really then dive into comparison of the treatments. Okay, so let's start and look at this clinical situation. The patient presented with a failed molar which had fractured tooth root. So the molar needed to be extracted. So of course, first of all, we did an X-ray. We saw that there is a bone below the interseptum. So first thing you do, of course, you extract the tooth. I'll show how to do it. But again, here, what we see here is nice bone between the roots. And I'm going to tell you that I am really ashamed now that in many of the cases before I started to doing immediate implants, I was not placing implant in the case like this. My mind was really heel-ridged mind, maybe because I was so extensively working on the zero bone loss concepts for healed ridges. But now, as I see it, 4 years ago, which in this case, and sure, you must place the implant immediately here and get all the benefits of this kind of treatment. Okay, so this is what I did. So you see interseptum bone, the osteotomy, implant was placed, and you see still the bone between the mesial and distal roots was so wide that I was really able to sink all the implant into the native bone. So should we consider that as an immediate implant placement? I would say probably even not, because when you have implant placed in all the native bone, so how does it differ from the yield-rich situation? There is no difference. We'll learn that there are type A, type B, type C in molar immediate implant placement, and in some of the cases we have the exposure of the implant thread. Not all the implant is covered with a native bone, then that's another story. But in this case, it is really perfect. Now, just placing the implant is not enough, not sufficient. So we made a individual healing abutment. I made it from plastic in freehand style. I'll show you later how I am doing this and why I think it is really simple and procedure. So those implant was placed. Then I made an individual healing abutment, and this is what you can see. It's 2 weeks post-operative. So I removed the stitches because during the extraction I had a flap raising mesiodistally. So you see the healing. 1 month post-operatively, everything looks very good. 4 months. So 4 months after implant placement, I see what? I see a perfect soft tissue profile, and which I never ever had before, which I never had with delayed implant placement and restoration. And this is how those tissues look after first removal of individual healing abutment. Well, so when I saw this, I was really amazed. I said, yeah, well, look how good the tissues are. So what you can do now is just make a final restoration, because the tissues are already prepared for you. The tissues are conditioned by your individual healing abutment. Before, this is how it looked after implant, after tooth removal, and 4 months post implant placement with individual healing abutment. And you can see that the contour is actually the same. Yeah, minor changes, which you would never have this kind of contour doing with delayed approach. What you can do now is just make a full zirconia restoration, delivery day, and when I place my zirconia restorations, I provide even some pressure on the tissues. I am not afraid to do that because his tissues are healed. But that is the difference between a provisional or individual healing abutment and final abutment. You can apply final crown. You can apply different levels of pressure to the tissues depending on the phase of the treatment. 1 year follow-up, everything is perfect. But when I recall the patient 3 years after treatment, you can see that the papilla fill is even better. So it looks like really nothing had happened to this root. Yeah? So we just substituted it with implant and completely full healing. And I go back a little bit again to emphasize. So not only profile is completely at the same level and not touched. Again, look at the papilla fill in posterior region. Now we'll discuss later why it is important. Well, maybe not for aesthetics, but for the food impaction. And food impaction is the most unreported complication from the patients. Over 50% of the patients, if you ask them, they would say that they are annoyed by impaction of the food. And lack of papilla is one of those reasons why the food is accumulating around our restored implants. What does the X-ray tell us? You see the placement, you see 4 months after placement, and delivery X-ray. So placement X-ray, what we can analyze that, yeah, we did grafting after implant placement and around our implant. Now we see the shape of individual healing abutment and then the low tie base. And as I said, that if you are doing implants immediately, you can sometimes use low tie base, which gives you more, let's say, chance to use more zirconia. But we'll talk about this very in detail when we will discuss restorative secrets. 1 year follow-up and 3 years follow-up. Completely integrated implant, zero bone loss immediate. Nothing will happen to this implant with time. And the patient is so happy because this final tooth was restored just after 4 months post-implant placement, and no food impaction, nothing, and just everything is getting better with time. We see not only maturation of soft tissues, because I already mentioned, you see the papilla fill is better compared to the 1 year follow-up. but we also see that the bone compared 1 year follow-up to 3 years follow-up is getting more dense, mineralized, corticalized. This is a sign that you did everything right. If there would be inflammation or something wrong, the bone is resorbing, not mineralizing. That was one part of patient's mouth. And you can see that, yeah, this is this immediate implant placement with restoration. Again, you see that no change in contour. But on the other side, the patient had missing molar. So the patient came to me already with this kind of situation. I'm sure if I could caught the patient before extraction of this molar, I would probably do immediate implant placement as well. However, here I already had the situation like this, so I needed to, again, place the implant here and see what is needed to be done. First of all, again, as you can see, how collapsed the tissues are. The patient has lost this molar only about 1 year ago, and you see how everything has resorbed, tissues has shrunk, bone has resorbed, and now we need to really reconstruct even before placing of the implant. So I raise the flap, and again here I apply my zero bone loss concepts from healed ridges, because I know that if you have thin tissues vertically, if I submerge the implant below the bone, I don't need really to augment tissues vertically. So here, if the situation allows, and it allows here, I'm placing implant subcrestally. Now, after that, I'm doing bone augmentation with allogenic bone, again, to really thicken the area of the neck, because the bone resorption was so huge that even with subcrestal implant placement, still I needed some bone grafting. And after bone grafting, I'm also using a soft tissue substitute to really cover the bone and also to augment tissues horizontally, because I'm lacking not only the bone in the horizontal direction, I'm lacking also the tissues, because extraction of the tooth results in two problems: lack of tissues, lack of soft tissues, and lack of the bone, which you need to reconstruct during the implant placement. Simple two-stage surgery, so I bury the implant, the bone, and soft tissue substitute. Everything is sutured, and this is how it looks after the healing. So we can see that still, with the bone grafting, with a soft tissue grafting, we still kind of are, not in that good situation, because we're still lacking, some tissues. Radiographically, we see the bone placed subcrestally. This is the bone substitute above the neck of the implant, and this is how it looks after 4 months of the healing. The bone has really resorbed and was started to be substituted by the native bone. And during the second stage surgery, I connect healing abutment and also do some, let's say, lingualization of the flap. Actually, I make incision a little bit lingually and push tissues buccally in order to gain more tissues during the second stage surgery. When tissues heal, still we are better compared to the initial situation. If I would compare this before implant placement and grafting, this is intermediate situation, and this is after the second stage surgery, you can see that I gained soft tissues to form some profile of the restoration. I gained, of course, the sufficient bone thickness for this implant to be stable. However, when we restored the final restoration, when they put the final restoration, we see that is still really not sufficient. Because what I see here, you can see this, that lack of the tissues. Now probably we should have been doing a third surgery, probably augmentation, additional augmentation of soft tissues horizontally would be needed here, but 3 surgeries already, the patient already had 2 surgeries. If we count extraction of the tooth, 3 surgeries already, extraction of the tooth, placement of the implant and grafting, and second stage surgery. So in this situation we decided to leave it like it is. And what I see with time, that yeah, there is a maturation of the tissues. You see the tissues are forming a little bit, but of course, you know, the lack of the tissues is still a problem. And we'll see to what extent it can lead. Another scenario, another picture is in the bone. You see delivery X-ray, and you see 1-year follow-up. Again, I see maturation of the bone, mineralization of the bone, which is a good sign. So, suprastally placed implant, high tie base, polished zirconia, gives you this perfect, let's say, example of yield-rich situation. However, when I compare it to the opposite side, well, maybe the soft tissue situation is not that good, because in immediate implant placement, I have completely, almost, contour did not change, while in the delayed implant placement, I probably do not have contour at all. I have a minimal amount of attached tissues that the implant really could function, but in order to have the same as in immediate case, in immediate situation, I would probably need to make additional grafting, and still probably that would not be enough. From the bone point of view, you see there is no difference. We can have zero bone loss concepts in delayed approach and the same in immediate approach. However, we can see again here the height of tie base different. Yeah, both implants are placed subcrestally. So in immediate implant placement, I can use lower tie base, and in delayed implant approach, I should not use low tie base because I would crush the bone. And in immediate implant placement, I can use low tie base because the bone is different in immediate implant placement above the neck of the implant. So we'll talk about this later when we will talk about restorative options. Another comparison, if this is not convincing for you enough that we should change the mindset from delayed approach to immediate approach, is another comparison. I call it side-by-side comparison, when we had 2 implants side by side. So in previous patient you had one side of the mouth with immediate implant and the other side with delayed implant, and you remember that even with 3 surgeries we were not sufficiently successful to regain the contour of delayed implant, while in immediate implant placement I just preserved what's there. I did not really need to regain what's lost. I just need to preserve tissues after implant placement. So side-by-side comparison. For me, these clinical pictures tell everything. So you see the difference in the profile of the restoration, because first molar was placed immediately, and the second premolar, which was already missing, was placed in delayed approach. The difference between individual healing abutment and standard healing abutment, these clinical images show why it is important to have individual healing abutment, even from composite. Well, I think we are thinking too complicated, thinking that composite as a material for individual healing abutment is something not sufficiently good enough. Yeah, zirconia is better, I mean titanium probably as well, but even the composite, if you are doing it correctly, because later we will understand, so what part of individual healing abutment is really responsible for this preservation of the profile. So it's really not difficult to understand. But anyway, you see the immediate implant placement really gives you a perfect profile, which is much worse compared to delayed implant approach, which at the end of the day results in different profiles of the restoration. Immediate implant restoration, you see, is like a tooth-like, and delayed implant restoration is like implant-like. So tooth-like, implant-like restorations. That's a fair and good comparison, that with immediate approach you can have tooth-like restoration, and with the delayed approach you can have implant-like restoration. A good visualization from the occlusal point of view, you see the lack of the tissues with the second molar and the preservation of the tissues with the first molar. That holds in situation that this implant is actually more prone for food impaction, which results being more prone to plaque accumulation, and which leads to more prone to perimplantitis. So I would say that immediate implants, if done correctly and restored correctly, probably are less prone to develop perimplantitis because of the contours, natural contours of the tissues are preserved compared to those contours which are lost in delayed implant approach. Well, what I learned from my experience with immediate placements in the same patient, immediate delayed comparison between nearby implants, I learned several things. First of all, immediate actually is much faster, and I would say much better than delayed, if of course indications allows to place those implants like that. Even with multiple augmentations, which we saw in cases I showed, it is still difficult to regain what's lost. I would say it's impossible to regain. Now, maybe it's good enough. Well, maybe it is okay for posterior region, and probably for anterior it's not good enough, but again, this is, the level of our perfection. So if we can provide the patient with unchanged contour of the restoration, which is less prone to perimplantitis, why wouldn't we do that? And last but not the least, that zero bone loss can be developed in both approaches. Here we must really divide two things: bone stability and soft tissue stability. It's not the same. Sometimes you can have bone loss and the tissues still be stable. And sometimes you can have no bone loss, zero bone loss, but if you are lacking the contour of the restoration, contour of the soft tissues, I would say this is as bad as having bone loss. Next thing we need to discuss when we talk about rationale for immediate implant placement is specific advantages of immediate implants. What do I mean by that, by specific advantages? Well, we compare two types of treatment, immediate implant placement and delayed implant placement. So for delayed implant placement, we see that the contour of the restoration, since the tissues are lacking, will create an overhang, will create a natural negative space where there is a possibility for food and plaque impaction and accumulation. Now you might say that maybe it is no big deal, but we'll see that the studies show that, of course, if you have overhang and poorly designed prosthetics, and in this situation is that you have a lack of the tissues, so that is the reason for overhang, those prosthetic inadequacies may lead to inflammation and periimplantitis development. Additional factor which we must consider when we compare immediate restoration, immediate implant placement result and delayed is formation of black triangles. So black triangles are not just a bad thing for aesthetics. In posterior region, those black triangles or not sufficiently developed papilla result in food and plaque accumulation. There is a study which studied 48 implants, and they found in the study that if the papilla are absent, those spaces are filled with food. It means that you can have a constant irritant around your implant restoration, which of course may predetermine periimplantitis development. Another study which specifically examined food impaction reported that in almost 45%, well, it is actually, we would say, half of delayed implants had food impactions. So food impactions, you mean every second implant which is not done immediately may suffer from food accumulation. If we look, you might say, okay, maybe the food impaction is because of the loose proximal contact, which is of course also a factor for food accumulation. However, in this specific study which I am discussing, 37% of embouchures which had food impaction had a tight proximal contact. It means that by chewing even with a tight contact, you have food accumulation around delayed implants which do not develop or are not possible to develop sufficient papilla fill. If we ask what patients think of that, the outcome of the study showed statistically significant difference. So patient reported statistically significantly less satisfaction with those implants which had food impaction. So we here have, as I already mentioned, I think one of the most unreported complication or lack of patient satisfaction, that every second implant which is made in a delayed fashion in posterior region suffers from food accumulation, which translates into dissatisfaction of the patient. And I really agree with that, because I had patients which were describing, let's say, how they feel with dental implants. And some of them said that, yeah, this is great. It would be even better if I would not have to think of you, doctor, after each lunch. It means that food accumulation is unreported complication, and patients usually do not mention this because they are, expecting pain, discomfort, like something. But if you ask them, you usually would get this answer, what the authors in the study got, that there is significantly more food around implants without proper soft tissue development. Of course, from clinical point of view, then food impaction leads to constant inflammation or irritation. And now we can make a conclusion. Well, it's not actually evidence-based. There is no study which observed it, but my point of view would be that immediate implants really do not have that kind of situation, because they have the contour which has been preserved by immediate implant placement and further procedures. Thus, they have less chance for food impaction, food accumulation, and irritation of the tissues. While implants, as you can see it here, without proper development of soft tissues, which is usually result of delayed implant placement, because let's say nobody is really thinking about papilla in second or third or first molar. Let's be honest, we are just thinking about function, that the implant would be in function. We attributed papilla fill completely to aesthetic area. There in front teeth, we don't discuss this. Yeah, sure, because black triangles in anterior region means unhappy patient, and means that then clinician must make some corrections. But while in posterior region, lack of papilla means more plaque retention or food accumulation, which was proved by clinical studies. That is why I would dare to say that implants without proper soft tissue contours and papilla fill would be more prone to develop perimplantitis. So we should think about that immediate implants, if everything goes well and everything is done according to the plan, have better chance really to withstand the insults from bacteria and plaque. Well, what should be then our, let's say, guideline? So what status of immediate implant placement should we achieve? So what is the threshold? How high should we have the threshold of success when we talk about immediate implant placement? And how can we, use those specific advantages which are offered to us by this immediate implant placement? Let's look at posterior region. Well, we talked about both posterior and anterior. Now, let's look at the best cases we can have in order to set ourselves a goal. Let's say this is the goal, this is what I want my implant to look like. Every implant placement should end up in this kind of the result. Let's take a look at another clinical case We have similar situation like previously. We have a failed first molar which needs to be extracted. So of course, first of all, when you have a restoration on the molar which needs to be extracted, first advice is of course to remove the restoration, not try to extract just with a full crown, because you can fracture and then the extraction process might be out of control. We remove the crown, and then of course what we do, we section the roots. If we're talking about posterior, I section medial from distal root, and we extract those separately. We will talk about this when we will discuss exactly placement of implants immediately in molar region. However, first thing you say that this procedure must be done with the most careful approach. Sometimes, and usually, you spend more time on extraction than on implant placement, because this procedure really then dictates how you're gonna place your implant. The molar is extracted. Again, you see sufficiently wide interseptum, and the implant is placed, grafted, and again, individual healing abutment from the composite is manufactured. Let's watch what is happening with contour with the flow of the time. Here we have just delivery of the individual healing abutment, and this is after 2 weeks. So we see fully healed ridge, fully healed extraction, and then the contour. Of course, with time, we see the change of the contour. 2 weeks, at 2 months, we still have a contour which is a little bit already more shallow, however, still in comparison completely the same as in native molar. With time, again, the contour remains the same. So after 4 months, because in posterior region we wait for 3-4 months, like for normal extraction. In case with normal extraction, we wait for integration of the immediate implant, because we do not just need integration of the implant, we also need the fill of these spaces in the bone. But if I compare, you see there is no really difference between 2 weeks and 4 months of the healing. This means that the contour really will remain the same. First disconnection of individual healing abutment, and wow, now look at these tissues. Look how nicely they have been preserved. You would never have this if I would just let the socket heal, or even if I graft it with some grafting material without an implant. So there is all package. You must take all the package, including implant grafting, individual healing abutment, maybe soft tissue grafting for anterior, but that preserves tissues right there. Scanning abutment, so we scan in order to take impression, and the final crown is delivered. During delivery of the final crown, you see the blanching of the tissues, and I'm repeating this, that with the final restoration, you can apply more pressure to the tissues compared to individual healing abutment, which must be passive. We'll discuss that in details when we'll talk about how to make individual healing abutment. However, here you can see that the contour remains completely intact. I would say this is how every implant in posterior region should look like. Perfect contour, no possibility for food impaction or food accumulation, and also full papilla fill, again, to avoid those problems. And initial situation and 1 year follow-up after the delivery of the final restoration in immediate implant, this, you could never achieve that with delayed approach. So that is our aim. This is what we should aim for in posterior implant treatment. Well, what about anterior? First of all, of course, let's say the determinants for anterior region are different, although they're very similar to the posterior region. Because in anterior region, we have patient evaluation. So patient sees the contour, patient observes presence or absence of papilla. That is, of course, why aesthetics anterior implants are more difficult to do. Maybe the same like posterior, however, the level of accuracy, let's say the space for mistake, is much less compared to posterior region. What should we aim for in anterior? This is, I think, again, the threshold must be as high as possible. And pre-treatment, with a pre-treatment situation with a failing tooth, and this is how the soft tissues look after first disconnection of provisional restoration, this is what we should aim for. And you see correctly three-dimensionally positioned implant with a protection tunnel, with bone particles integrated into the soft tissues. Those are the components which are needed for success. If we follow up this case, you will see that the tooth was failing and needed to be extracted. Now, of course, if we analyze the case, so it should be relatively not that difficult. Why? Because thick biotype and also shallow papilla. So we see that the papilla actually here is missing, and even around natural tooth, we see that the papilla do not really grow deep into the embouchures between the teeth. So it's a relatively easy case. Extraction of the root, again, very important to leave intact buccal plate and intact soft tissues. Positioning of the implant, and I think that guided restoration in anterior region must be a must. It means it should be a part of the protocol, because you will see that the disbalance of implant position in anterior regions has much more severe consequences compared to this disbalance in posterior regions. So, for example, in posterior immediate upper molars, sometimes we place the implant in the palatal root on purpose, and it goes off if we have bone there. That is not really possible to have in anterior region. We need to have in a precise three-dimensional situation. That's why the guided restoration, if we want to have success in immediate placement, I think guided surgery in anterior cases should be the must, and we should not make any compromise here. Positioning of the implant. And in this case, you clearly see the difference, what I was talking before, that in anterior cases, the position of the implant usually must leave space for bone grafting. It means that you cannot engage the buccal wall. That's why part of the implant threads are left exposed. So that is the difference between when you place the implant and it sinks into all the native bone. Those cases I don't even consider it as immediate cases. Now this is really an immediate case. Here you see the packing of the bone around these spaces. We will learn why this bone needs to pack, how much of the bone we need, is the particle size important, and can we overgraft these cases? So it's not just blindly putting the bone to fill the gaps. There is again the procedure how to do it wisely and correctly. Next step in anterior cases is provisional cylinder. Then with this cylinder we are really connecting prefabricated provisional crown, and then we remove it, trim it, and then we put it back to the implant. Here again, of course, it's important to take the implant out of occlusion at least 1 millimeter and also from the dynamic occlusion. This implant restoration cannot take part in protrusive moment or laterotrusive or canine guidance. So anterior tooth cannot have a contact in this kind of mandibular excursions. That's why we should make it shorter and sometimes make it a little bit more buccal, as you can see it here, because that's not a mistake. You see that the provisional implant restoration is made a little bit buccally. It's not that we glued it in a wrong position. This is done on purpose in order to avoid the contact of this restoration during excursion of the mandibular jaw. And this, another very important point, must be discussed with the patient before the surgery, that the provisional restoration won't look exactly like the natural tooth nearby. It will be a little bit shorter, it will be a little bit in the front, but you will have the tooth. So that's what you need to tell the patient. You will have the tooth, but it will look a little bit different, because in this clinical case, if I would have made this provisional restoration like the neighboring tooth, which means that I need to put it backwards, it means that during the excursion, during the movements of mandibular jaw, there will be inevitable contact. This might really lead to the complication, because we do not really need to have this movement for provisional restoration. In this clinical picture, you can clearly see what I was talking about. You see the incisal edge is further buccally compared to the natural tooth, and also you can see that the provisional restoration is shorter. I mention again, this is done on purpose, not just, it happened by accident. This allows us to avoid any excursions, any contacts during excursion of the mandibular jaw. Of course, when we look at soft tissues, just look how nicely it has been preserved. This means, again, that our treatment was successful. I always enjoy taking the pictures after the first disconnection of the provisional restoration or individual healing abutment, because clearly you can see all the prerequisites of successful immediate implant treatment. So position of the implant, tunnel or channel of protection, maintenance or support of soft tissues, those things we will talk in detail in the next episodes of the zero bone loss immediate. And final restoration. Final restoration was not done by me, was done by referring dentist. Of course, we can argue a little bit about probably the color, maybe it doesn't really blend that much, but what I was responsible for, to have the contour which would really be ideal and ideal with the neighboring tooth, I think that was really achieved. And also, look again with the final restoration, surely then we're making it as a copy of the neighboring tooth. So it's not short anymore, because why? Because of course implant is integrated already. So it can withstand all protrusive and laterotrusive and occlusal forces. That's why you see the difference. Again, here we have failing tooth. This is the final restoration. But the main difference, of course, is between the provisional restoration and the final restoration. If we follow up all the procedure from the tooth, extraction, placing of the implant in three-dimensional position, grafting of the jumping distance and surrounding tissues, provisional restoration, healing, and final restoration. Again, from prosthetic point of view, look here, you see that the incisal edges coincide. So again, they are made in the same line. Not like this, but this is done on purpose to avoid any occlusal interferences. Before treatment, after treatment, zero changes of the soft tissues, and that's what is our threshold for immediate placement. That is why immediate implants are really made for. That, in my opinion, it is much more easier to regain, not to regain, but to preserve this soft tissue contour and papilla around immediately placed implants than in delayed approach. Well, I started to talk about delayed approach. Okay, so let's look how, if we entered, let's say we had a patient in anterior region already without a tooth, or we simply do not believe in immediate placement in anterior or posterior tooth, so we extract the tooth, we torture the patient with provisional removable restoration. But if we are comfortable with that, and again, as a clinicians, it's our choice. Let's look, even with highly skilled surgical procedures. Again, I want to emphasize this. Even with highly skilled trained surgeons and difficult multiple surgical procedures, are we able really to regain the same amount of the tissues? Here is the clinical case. We already have the patient after tooth extraction. Patient came to our clinic already without a tooth, so only with a flipper. And sure, here of course we did not really had a choice again what to do. Again, we need to go through all the augmentation procedures. So implant placement, soft tissue thickening membrane, then really grafting or over-grafting with bone to have more bone than it's needed. I mean, usually we tend to over-graft because we expect some shrinkage. And suturing of the tissues working in two-stage approach. Well, here is how the patient came, and this is after the surgical part. You see that, of course, we have more soft tissues, bulkier soft tissues, and now it's the work of prosthodontist maybe to play with those tissues even a little bit more. After second stage surgery, I see that we have a potential to have papilla, because soft tissue height is okay. However, of soft tissue width or horizontal thickness, I have a little doubts, because you can see that already with the healing abutment, we can see that it's a little bit becoming gray. So the tissues have grayish appearance. It means that they probably are thin. As a prosthodontist, I'm doing here a really good job, because formation of soft tissues with a provisional restoration really pushes tissues buccally, and we get really the best outcome of we can get from this clinical case. And if we look at here from this perspective, oh, looks very good. I mean, you have papilla, yeah, you have the contour, yeah, looks fine. However, it depends on the perspective from which you make the picture. So from horizontal, if I make it like that from the front, maybe there is no difference. But if I would look at this situation from, let's say, occlusal plane, we also can spot, we already spot the difference between neighboring tooth and the implant. Of course, if we compare initial situation and the final soft tissue thickness and implant position, that is completely great. In terms also we have stable implant, well, with certain loss of the bone. However, that bone loss is statistically or clinically here not significant, because let's say the soft tissue thickness allows us to have that kind of bone loss. But if I make it this picture larger, and especially if I put a immediate implant situation with delayed implant restoration, we already see the difference in contour. So contour from occlusal perspective, it is really most difficult part to maintain. And the final restoration contour, check the neighboring teeth, and final restoration here. So you can see that there is a lack of the tissues, there is a collapse of the tissues, and yeah, and if we even compare crestal bone stability, we see the difference. The answer is here that, as I said, in immediate implant placement, implants usually go deeper compared to the healed ridges. In healed ridge situation, here the implant was placed according to the literature, according to this historic and conventional rules at the level of the bone. And it means that, you know, maybe procedures of connecting, disconnecting of the abutment and augmentation processes had its toll on crestal bone stability. While in immediate placement, the implant is deeper, and you can see that actually we have a better bone stability. I mentioned it before that probably this bone loss does not really have any clinical significance. But if we just look from crestal bone stability, immediate implants have potential to have better bone levels compared to implants placed in healed ridges. Well, then let's compare, okay, from patient point of view and also from the surgical point of view, immediate with delayed approach. And if we have the same outcome, or in this case, as you saw, even better outcome with the immediate placement, now let's, divide the process and look at each step. First step, of course, which is important for the patient, is the fixed provisional. So fixed provisional, it's a must when we talk about patient comfort and social acceptability. So in immediate implant placement, we placed implant, Usually the fixed provisional comes at the day 0 or the day 1. It means the same day we provide implant with patient with fixed provisional. While usually in delayed approach, since we cannot load the implant because there is no implant, it usually takes about 240 days. So the difference is huge, half a year difference between those and those situations. Provisional at the 0 day and in immediate restoration, immediate implant placement, and provisional and 240th day in the delayed approach. Now the outcome was, you saw almost the same, although immediate actually was a little bit better, but just think about the contour of the patient, comfort of the patient. Now profile, no change, collapse. In delayed approach or early approach, if we compare these two situations, there was a small collapse about 1 millimeter. Maybe it was not detectable for the patient, but here we're talking about not the patient, we're talking about general outcome. So does 1 millimeter matter horizontally? I think yes. And if I can achieve this by placing implant immediately, of course, according to the rules, if the indication is correct, if the patient can accept immediate implant placement, so I would go for immediate. Why I then need to go for collapsing all the tissues and then make all these surgeries to reconstruct and still do not achieve the outcome as immediate placement can achieve. We talked about the surgeries. Okay, let's count them. In immediate placement, there is one surgery. So you extract tooth, you place the implant, you graft the bone, you graft the tissues, it depends on the situation, and that's all. While in delayed approach, there are 3 to 4 surgeries, and sometimes they are not enough to get the good outcome. So you have extraction, you have implant placement and grafting, you have the second stage, and sometimes correctional grafting to boost the tissues more, because they shrink with time during the bone grafting, and still you have 4 times more intervention compared to less intervention. If we ask the patients what they think about this, so better don't even ask. So patients much more prefer immediate implant placement because of this, let's say, the longevity of the procedure, and also these drawbacks which we have discussed just now are avoided if we're doing the implant immediately.